This is a lecture for GERD Management Pharmacology. So this is for Module 4, Indigestion, Exemplar 4A, Gastroesophageal Reflux Disease. I'm simply going to cover the medications or pharmacology, pharmacological management. In your text, it covers it starting on the bottom of page 239. There's a couple of paragraphs. Notice a safety alert there, and then they have a chart with medications on 240 and 241. I did go back through the PowerPoint and reposted it. I took out the page numbers from your drug handbook. You're more than welcome to do that. I just want to keep you focused as you're learning about pharmacology. You will be using your drug handbook for your care plans and your med sheet on there. I want you to know how to use the book, how to reference into it, but I don't want you getting confused. So if you notice on this picture, GERD, antacids, H2 agonists, proton pump inhibitors, prokinetic agents, and this also lists mucosal protective agents, which we're not actually going to cover in here. Those are not really used for GERD. They're used more for, for ulcers to coat. So I'm not going to cover that one, and you're not responsible for that. So one of the options, your antacids, they neutralize the stomach acid. They come in many forms: aluminum salts, calcium salts, magnesium salts, and sodium salts. Your text simply lists the aluminum one, such as Alternogel would be the most common one. Often we'll see Alternogel used with as the option in a renal failure or renal impairment patient because they can't have the magnesium and the calcium and the sodium. Calcium salts, magnesium salts are another very, very common. Calcium salts would be like calcium carbonate. A common one for that is your Tums. The sodium salts, sodium bicarbonate. People actually used to take a sodium bicarbonate, but they found it actually can cause increase in the acids in the stomach. And then you have your magnesium salts, which are very, very, very common. And an easy way to remember the ones with magnesium, or most of the ones with magnesium in it, have an M in the name, such as Mylanta and Maalox. So somebody that's restricted from having magnesium, you don't want them to have the ones with the M. Gaviscon is a combination of the magnesium salts and the sodium bicarb. So back in my lifetime, actually as a nurse, that's all we had were the antacids. I've been a nurse a long time. We had antacids, and then we got some other things and eventually worked our way to proton pump inhibitors, which we will talk about. The antacids work very rapidly in 5 to 10 minutes, but they only last 30 to 60 minutes, just neutralizing those acids. These antacids are all over the counter, which there's my thing on over-the-counter medications. I understand, but people don't know how to use them, and they are overused. So you're worrying about electrolytes if you're shoving aluminum, calcium, magnesium, or sodium into somebody, or a combination of the above, if you're decreasing their acids in their stomach. So you have to be concerned with bowel obstruction, constipation, impact on the kidneys, and caution if they have any kind of renal impairment, and it can throw their electrolytes off balance. Taking antacid about an hour after eating or when they have some heartburn. If taking it for symptoms at night, they should take it without food, and antacids are not to treat not designed to treat ulcers. They're just neutralizing acids temporarily. Then the other group that came after the antacids were the H2 antagonists. They're blocking the histamine. There's H1 blockers and H2 blockers. When we talk about antihistamines for allergies and things like that, those are H1 blockers. The H2 antagonists block the H2. It's a type of antihistamine that's secreted in our parietal cells in the stomach. So these H2 antagonists or H2 blockers, which they're often called, bind and prevent that histamine leak that causes the secretion of acids. It can inhibit up to 90% of that acid production. It reduces the hydrogen ion release, which is your acidic component. Most people will take it with their first meal of the day. Sometimes they'll take it with their evening meal. They work better if they're taken on an empty stomach, but it's not required, but it can. They're supposed to be for short-term use between 2 and 6 weeks. They're not for somebody to take on a chronic basis, but of course people do. It's over the counter and there's no regulation. It takes 30 to 90 minutes for the medicine to work, but the benefits can last several hours. And usually if they have symptoms occur within 24 hours, they get an improvement of this indigestion. They're just a short-term preventive medication to decrease stomach acid. Many different forms. They come oral, IV, and actually I didn't realize there was one that comes in an injectable IM form, which is cimetidine. I've never given it IM. I did not know it came that way. I've only seen oral and a few of these that come intravenous. Some are over the counter. More and more are prescription. Usually the prescription is a higher strength. They should be taken at bedtime unless they're told to do at a different time. If you think about it, hopefully you're learning on your GERD. A few things that cause it, with that sphincter being not very effective and acids are leaking around it and up into the esophagus, causing that heartburn and pain. So when you lay flat, you have more of this reflux, so they shouldn't eat within a few hours of bedtime, and that's where this medication is helpful to decrease that acid production while they're laying down. Some people will take it in the morning before they eat anything. Sometimes they're taking it twice a day, depending on what they're taking it for and what they've been instructed to do. They should take the H2 antagonist with a meal. I did put your Pearson page on here because it's still on that text, and page 240. This picture shows some PPIs, which are over here. These are your H2 agonists, your Tagamet, which cimetidine is Tagamet, famotidine is Pepcid, ranitidine is Zantac. If you notice the name in there, and the other one in your text is Zatidine or Axid, but these are the most common, these three. So cimetidine, ranitidine, famotidine. So you can look at the end of them and recognize that those are H2 blockers or H2 antagonists. I'm looking over to see what else they give you here. Giving these intravenously, which I have done. It's do not give with other drugs. It's given in over 15 to 30 minute period. Never ever give it a push. It's in a diluted solution and like a piggyback. Lots and lots of drug interactions with the H2 agonists, antagonists. I've got some listed here. Anticoagulants, beta blockers, benzodiazepines, and tricyclic antidepressants. So if they decrease the metabolism, so the drug is not broken down, there's an increased risk of toxicity on numerous of the medications. Caution in the older patient, they have an increased chance of having confusion and dizziness. Dizziness is a common side effect, but more so in the older population. It is contraindicated in pregnancy and breastfeeding because it has passed through the placenta and into the breast milk. They're all to be avoided in children under the age of 16. Extreme caution with hepatic or renal impairment. Again, you're messing with the acid production, acid and electrolyte absorption. So the common side effects: headache, dizziness, rash, and fatigue. For everybody, a headache seems to be very common. With your drug interactions, cimetidine, which is Tagamet, which I don't think needs to be over the counter, it interacts significantly with a lot of medicines, including aminophylline, which we will talk about with respiratory drugs, warfarin, which is your Coumadin for your blood clotting, phenytoin, which is Dilantin, which we'll talk about with seizure meds, and with theophylline, another respiratory drug. Anytime you decrease in acid production, you have an increased risk for certain infections, such as your H. pylori, which is more so with your PPI, so I'll touch on that more there. Back to your cimetidine or Tagamet, with significant drug interactions, it also can cause gynecomastia, which is breast growth, male, female. And ranitidine and famotidine, which is your ranitidine is Zantac, famotidine is your Pepcid. High risk for thrombocytopenia, which is penia means small, so your thrombocytes are small, so you're going to look for a decrease in your platelet count, which is an increase in bleeding. More so also interacting with your warfarin, which is affects your clotting factors too. Teaching the patient to report adverse effects such as diarrhea, confusion, rash, fatigue, malaise to their primary care provider. That's it on these. Proton pump inhibitors. These are the most popular. They've been over the counter for several years now. They actually suppress the proton pump. They suppress the secretion of hydrochloric acid into the stomach. There's numerous out there. These are the most popular: esomeprazole, which is Nexium, omeprazole, Prilosec, pantoprazole, which is Protonix, lansoprazole, which is Prevacid. They're very potent to reduce that acid secretion by irreversibly binding the hydrogen and potassium adenotriphosphate, if you remember your ATP, or your protein pump that's in your parietal cells, but they're often overused and misused. This is an excellent picture of all the problems that can happen from PPIs. And I'm going to come back to this. So what is a proton pump inhibitor? Integral membrane protein in the parietal cells of the stomach is your proton pump. Your adenotriphosphate, if you remember from your Krebs cycle, your hydrogen, which is an acid, and your potassium ions, it blocks that to prevent the secretion of those acids. These are the ones I listed on the prior. Some teaching: do not crush. And when I says do not crush, that means you cannot crush this and put it down an NG tube or a feeding tube. It needs to be taken whole because it's broken down later in over a period of time. So do not crush it because the full impact is there, and that can be dangerous. Anybody taking these need to increase their calcium intake, and you want to monitor their liver enzymes. In your text, let's see if it says anything. It's the drug of choice for GERD because, again, GERD is that reflux coming up. Also, GERD can be caused because they have a hiatal hernia. So if they have a hiatal hernia, that stomach is constantly coming up through that tear in the diaphragm into the esophagus. So if you block those acids, the proton pump in there, it decreases the terrible symptoms that come with the hiatal hernia and the GERD. Administer 30 minutes before breakfast and or at bedtime, depending on whether it's once or twice a day. Monitoring your liver function tests. It lists your liver function, your AST, ALT, also watching for your bilirubin. Overuse or extended use can lead to hypergastremia, where you have a rebound of acid released by your stomach. People that when they first discontinue a PPI, they can have this rebound and really bad symptoms. So you want to use them for a short period of time, about 6 to 8 weeks, depending on what they're being used for, and also to not stop them abruptly because of that rebound of acids, but to taper them off. Overuse of proton pump inhibitors is common. As many as 40 to 65% of hospitalized patients receiving PPIs do not have an ongoing indication. I have so many people that I try to get off. I try to talk to them about weight loss, about changing the foods they're eating, positioning, not eating a few hours before going to bed, having the head of the bed elevated, all these multiple things, not wearing restrictive clothing on the belly, but they want to stay on their PPIs, even though there is great risk. There's this osteoporosis or fractures. I was on PPIs for years. I had ulcers in my 20s and then several times after, and so I was on H2 blockers or H2 agonists. And when the PPIs came out, they immediately put me on a PPI. So I was on and off of PPIs for different courses for quite some time. And at 50 years old, I'd had postmenopausal from a hysterectomy, and being on a PPI, I had a stress fracture and a significant osteopenia, borderline osteoporosis at 50 years old, even though I was physically active and in the Army. It was from the calcium blockage from the PPI. So I can say I have not touched a PPI since. I lost weight. I changed what I was eating. I've done so many things, and it has took a while, but it has been effective. Another risk here is C. diff. Again, more so than your H2 agonist, you will see C. diff in patients with PPI use, usually prolonged use, but not always. It's blocking the natural bacteria in your gut. So it's increasing that risk because if our natural bacteria is not there, you can have an overgrowth. You might and end up with C. diff in the growth Clostridium difficile. Low iron, vitamin B, causing different kinds of anemia because you're blocking those acids, which that is where you are absorbing your iron and your vitamin B12 through those parietal cells, and if you're blocking the acid there, you cannot absorb them. There can be as much as a 41% reduction in calcium absorption after just 14 days of using a PPI. They can have secondary low calcium or hypocalcemia, low potassium hypokalemia, and a significant risk for hypomagnesemia or magnesium depletion. The the fracture risk are more so in the wrist, the hip, and the spine. Mine was in the heel because I was doing rocket marching at 47, which was a whole nother story in itself. Okay, so pneumonia. Also risking for pneumonia, again, because of decreasing these acids in the stomach. And then you have a rebound, an H. pylori that can overgrowth, and non-H. pylori bacteria that can cause ulcers, and right there in your diaphragm and reflux and causing problems with pneumonia. Lots of kidneys problems with it because they've seen acute renal failure, acute kidney injury because of all the shifts in your electrolytes and your acid secretion. I'm going to go back to this other picture that I said I was going to come back to because this is just a really good picture. The central nervous, the dizziness, headache, somnolence, and confusion are some systemic effects, and they are finding now there is an increased risk of developing dementia for prolonged PPI use. There's lots of rashes, alopecia, which is loss of hair, respiratory effects of cough, hoarseness, pneumonia. I mentioned some cardiovascular effects like arrhythmias and heart failure, the bone loss, the low magnesium, hypomagnesemia, diarrhea and constipation, more so constipation, acid rebound, dry mouth, gastric cancer. And they're now finding too, because of all these shifts, that there's an increased risk of developing systemic lupus erythemia, or what everybody calls lupus. So these drugs are all over the place. You will encounter so many patients that are taking it, and it's not a benign drug. That's why I get so upset with some of these over-the-counter medications and trying to teach people. Okay, the last one we're going to cover is metoclopramide. The brand name for metoclopramide is Reglan. It is the only pro-mobility or GI stimulant, pro-kinetic, that's pro-movement, that is on the market. It used to be used an awful lot, and then they found some major adverse effects with this. So it's a gastrointestinal stimulant or prokinetic. It blocks the dopamine, serotonin receptors in the central nervous system. Short-term use treatment for GERD, contraindicated in lactation, caution with high blood pressure, Parkinson's, and depression. It comes in tablets, liquid, and disintegrating tablet. It is not to be used in children. There is no safety. Safety has not been established. It works as a cholinergic. So if I say a cholinergic, remember your parasympathetic or the cholinergic side of your nervous system. So antiemetic. Remember your sympathetic side, you have an increase in the saliva, increase in your gut. The opposite of an anticholinergic, so it's going to increase that motility through the gut. Can be used as an antiemetic to decrease nausea by pulling things through the stomach faster. It causes a contraction of the gastric muscle, so it can help with that peristalsis, help with that sphincter squeezing, and help with the nausea. Increases peristalsis without stimulating secretions. It also helps with the nausea because of blocking dopamine in the chemoreceptor trigger in our brain, where that's our nausea trigger, chemoreceptor trigger zone. It's contraindicated in gastrointestinal obstruction, perforation, or hemorrhage. Well, think about that. If you have an obstruction, a bleed, or a tear in the intestines, the last thing you want to do is increase the movement and stimulation in there. So those are definite contraindications. Contraindicated until about 4 days post gastrointestinal surgery. They used to actually use it a couple days after surgery for paralytic ileus, trying to get it to get moving, and discovered that they need to wait. Contraindicated in people with pheochromocytoma and in breastfeeding. Yeah, contraindicating lactation, I said that. Used with extreme caution with hepatic and renal impairment in the older population. Should not be used in adults and children. If it is used, they use a pipette for a specific measurement. Because of the significant CNS here with blocking these receptors in the brain, it can mask underlying disorders such as meningitis or increased intracranial pressure, or even seizure. It's used caution with seizures because of masking some of those CNS symptoms. This is a really good picture because of the tardive dyskinesia remedial symptoms and central nervous system depression and gastrointestinal upset. Contraindicating a patient with epilepsy and antipsychotic drugs that can cause these symptoms. We just talked about some of those in mental health that can cause these extrapyramidal symptoms, which is your antipsychotics. Like, look here. Looking in your text on page 241, see if there's anything they've added that I didn't say. Increased gastroparesis, that can be a common problem with people with diabetes, sometimes with other problems that has caused the stomach where it no longer squeezes and pulses things through, so they will use this. Unlabeled use for hiccups. I've never seen intractable hiccups, but I understand this sometimes has been used effectively. So, intestinal obstruction, lactating. Take 30 minutes before meals and 30 minutes before bedtime. You need the 30 minutes before meal to get the gut moving before they eat. Should be stored in light-resistant bottles because it is sensitive to light. And the common adverse effects, fatigue, extrapyramidal symptoms, which I have listed pictures of here, diarrhea, in very rare cases, hypertensive crisis. So that is the end of your pharmacology for GERD.